Good morning. Thank you very much. As a background, we know that morbidly obese patients, they have a different kind of GERD than the normal weight patients. Evaluation prior to bariatric procedures, we know that we see a lot of patients with so-called silent GERD, asymptomatic GERD. And there are papers out there that show up to 68% of silent GERD in those patients in evaluation prior to bariatric procedures. There's also a trend towards laparoscopic sleeve gastrectomy, as it has become now the most frequently performed bariatric procedure to date. So we have those two statements. We know that we have a lot of silent GERD in bariatric patients. We have sleeve gastrectomy as a frequently performed procedure. We do not know really how it plays together. We know that sleeve gastrectomy is known to worsen preoperative reflux and results in de novo GERD. However, we do not know what the role of silent GERD is so far. So in this study, we collected prospective data of patients with primary sleeve gastrectomy between January 12 and December 2015 in our university hospital. So we excluded patients that that had hernias, hiatal hernias more than 4 centimeters, and patients that had hiatal hernias that we didn't repair because of morbidity or intraoperative decisions. We also excluded patients that were converted to Roux en Y for early leak, that we felt didn't have a postoperative anatomy that was right, and patients that didn't have a preoperative 24-hour pH manometry, which is our usual evaluation in all patients in our hospital. Sleeve gastrectomy was straightforward, 20 and 32 French bougie, and all hiatal hernias that were greater than 1 centimeter were addressed by hyaloplasty. Indications for sleeve, obviously it wasn't the first go-to procedure, so we reserved this for high-risk patients, patients with higher BMI. We defined this as BMI over 50, but obviously patients' wishes play a role. Again, every bariatric patient underwent a specific evaluation. They validated questionnaires. It was once this Gerd HR12, we heard this before, and another validated questionnaire for frequency and intensity of Gerd, upper endoscopy, 24-hour pH manometry of PPI, and upper GI studies. Follow-up, the routine bariatric follow-up, clinical follow-up every 6 months, with questionnaires, gastroscopy after 1 to 2 years, and 24-hour pH manometry after 2 to 3 years. However, so we want to do this in all patients. As you know, it's not that easy to really convince everybody to undergo functional evaluation. Then, definition of silent GERD is absence of symptoms in combination with esophagitis grade LAB or abnormal esophageal acid exposure. So what did we find? We had 238 patients overall. We included 13 for the reasons I called before, incorrect anatomy, and so on and so on. The mean follow-up was 32 months. However, I mean, we see this afterwards. Actually, at the time point we cut and we looked at was 2 years. We lost 3 patients to follow-up before 1 year, so we included them also. So all in all, we ended up with 222 patients that we included. 103 male and 119 females. Pre-op BMI was 49.6, and after 1 year, 34.7, and in the further follow-up, 32.3, which is quite a standard weight loss. So all patients received gastroscopy after a mean of 1.5 years, and pH metry was performed in 63% of patients after 2.3 years. However, it was performed, and we see this in all patients with asymptomatic GERD. So what did we find? Pre-op, 52% of patients had no Gerd, no symptoms and no Gerd. 25 or 1/4 of patients had silent Gerd, so they didn't feel it. And 23% of patients had symptomatic Gerd. This changed to post-op. 38% didn't have any Gerd at all. Silent Gerd reduced to 10%, but symptomatic Gerd was more than half of patients. And to go a little bit more into details, so patients that had no Gerd before, half of those patients stayed with no symptoms, but 40% had the novo Gerd. Patients with silent reflux before, 2/3 of those became symptomatic. And patients with symptomatic Gerd, to 60% stayed symptomatic, and to 37% were relieved of Gerd. So, to look back, symptomatic Gerd after sleeve gastrectomy, so we have almost half and half, 48% that have no Gerd at all, and of the rest of 52% have persistent Gerd, 14. New onset, actually 52%, 21%, and silent 17% before. So of patients that didn't have Gerd before, 85 had de novo symptoms, which results in 73%, which is quite a large number. So in conclusion, sleeve gastrectomy leads to a considerable rate of postoperative Gerd. De novo Gerd consists of around half of preoperative silent Gerd and completely de novo Gerd. Most patients with preoperative silent Gerd became symptomatic. And even though there are limitations, especially in definition of Gerd, these data, I think, justify comprehensive preoperative evaluation and post-operative follow-up. Thank you very much.